Welcome to ATCM, the Emergency Medicine channel. Today we will be discussing a case of acute liver failure, a patient who was presented to our ER. So, a 42-year-old male was presented to our ER with a complaints of generalized fatigue, vomiting for over the last 10 days. And the initial 10-second assessment, patient was drowsy, but he was responding to our commands and was speaking relevantly in full sentences. Coming to the primary survey, patient's airway was patent. There was no pooling of secretions, no hoarseness of voice, no gurgling sound, and he was maintaining the airway. Coming to the breathing, patient had a saturation of 99% in room air and had a respiratory rate of 20 per minute, and air entry was bilaterally equal. There was no added sounds and there were no signs of any aspiration. Patient's circulation, patient's BP was
What are the respiratory disorders you see in liver failure?
Sir, tachypnea leading to respiratory alkalosis. Then if low sensorium is there, can lead to aspiration. Then if there is a hepatopulmonary syndrome and all, there will be features like orthodiopsia.
Okay, orthodiopsia will be there. Then
elevated lactate
then
and
pleural
metabolic.
effusion can be there. If there's ascites related pleural effusion, then
Hepatic hydrothorax.
hepatic hydrothorax.
then ascites are in a distant abdomen itself pushing the diaphragm upwards, causing respiratory difficulties, like reduced functional respiratory capacity.
Then metabolic acidosis, if it is also there, then acidotic breathing.
Okay, rapid breathing.
Then it is immunocompromised state, so there is chance of secondary infections leading to pneumonia.
Okay.
So coming to circulation part, patient was having a blood pressure of 120 over 70 millimeters of mercury. Pulse rate was 88 beats per minute. It was regular in rhythm and had good peripheral pulses felt over all areas. Patient's disability.
Heart rate, what are the things you need to remember in liver failure?
So one thing is like if there is a fever or associated things, there will be like tachycardia. Then liver failure,
Infection can produce
tachycardia. Then liver failure, if it is like alcoholic and all, arrhythmia's chance are there. So AF and all will be commonly seen. So we have to rule out that. Then severe jaundice and all can cause like basically it is related to obstructive jaundice and all. There will be bradycardia.
Bradycardia.
The bilirubin deposits over the sinus node.
Okay, synod. Inhibition.
Will be there.
Practically, the most important thing will be most of these patients will be on propranolol. Okay, so most of the findings will be masked. Okay, CLD patients invariably are going to be on
Propranolol.
So those things you need to remember. Fine.
And coming to disability, patient was having a like GCS of E4, V5, M6, and his pupils were 2.5 millimeter bilaterally equally reacting to light. Exposure part, patient was febrile and he was having a JRBS of 118 milligram per deciliter. So after the primary survey, there was no emergency intervention requiring currently. So we went ahead with the sample history and the secondary assessment. So sample history, patient is not having any known allergies. He is a alcoholic and has been consuming alcohol for more than like 10 years on a day-to-day basis. And the patient...
Alcoholic means what?
Sir, like alcoholic, basically if we can consider a person as like alcoholic if the person, if it is a male, if he is taking like more than 4 standard drinks a day or more than 14 drinks per week, or if it is a female or like a elderly adult, if it is like more than 3 drinks a day or more than 7 drinks a week, we can consider as like a high risk like alcoholic.
Alcoholic is different. Physical dependence and psychological dependence and produces his social life into danger. Then only we can tell it is alcoholic. Somebody takes this much amount is not alcoholic. If he is not dependent on that, if it is not creating any problem to his behavioral this one, then you cannot tell him. Cannot tell him as an alcoholic because it's a psychological disorder, psychiatric disorder. To tell him that alcoholic, these things should be there. What you told is that alcohol
drinking
drinking
pattern, and if the patient, like according to DSM-5 criteria, if we can say it as a dependence or alcohol use disorder. Now the term is alcohol use disorder. So there the criteria is like there are like around 11 points, at least like if 2 or more are satisfied, we classify it as mild, moderate and severe dependence or the use disorder. So as I told, like it can be like tolerance requiring more amount of alcohol with over time, then spending more time like for the alcohol or substance related issues and all those things. So he's an alcoholic, and patient now, like the issue is like he
these are legal terms, so it may not alter your treatment part, but when they go to court or somewhere, that terminologies will create problem.
So the patient had complaints of generalized fatigue. So he planned of going for a de-addiction. So he went to a de-addiction center like around 20 days back, and like around 1 month back. And that time, like he was started on disulfiram, acamprosate, and lorazepam. And following that, he was discharged to home, and he was taking these medicines, but he developed more like fatigue and intermittent episodes of vomiting was there. So he again consulted the doctor, reduced the dose, but even with that, his symptoms were persistent.
Many bystanders, relatives, they always think that disulfiram can be given without patient's knowledge. Is it correct or not?
No, sir. Basically, disulfiram, thing is disulfiram, the mechanism is that it causes a like a aversion, not like a aversion, it causes some effect that will lead to vomiting or the symptoms, so that patient can't take a vomiting. But if we are not knowingly given, something anti-craving should be given, something like acamprosate. But ideal thing is the patient should be motivated and started.
Patient should be counseled and motivated. Then only we should start this type of medicines. Otherwise, they develop disulfiram reactions after taking alcohol. That is more dangerous.
So here the patient had vomiting episodes, and patient denied any intake of alcohol during this treatment. And later one day he developed a fever that was like around 12-15 days back, and was symptomatically managed in an outside hospital. And since the patient's fatigue and all persisted, they went to a hospital, got admitted there, and was evaluated, found to have a bilirubin of 1.5. With the SGOT and SGPT level like more than 2000, and there the patient's dengue IgM turned to be positive, and he was admitted in the hospital for a period of like around 1 week. And over this time his SGOT SGPT was almost like around about 2000 range, but his bilirubin.
Why bilirubin is low in this case?
Sir, bilirubin low can be like one thing is an acute, maybe like acute thing.
What is the thing? Why bilirubin is low when the SGOT SGPT is very high?
Initial phase, the enzymes.
If you understand the mechanism, it is very easy. Bilirubin is metabolized in liver. 25% of the normal liver cells are required for the bilirubin metabolism, what we are having. Okay, that is enough. So even if you have a liver failure in acute phase, 25% will be still working. That time bilirubin will not elevate. That's why most of the liver disease, acute liver disease, you get normal bilirubin, but SGOT, SGPT will be high. After some times that liver, that part of the liver is also involved. Then slowly bilirubin increases. SGOT, SGPT will not elevate that time because liver cells are already damaged. So they will start coming down. Then only bilirubin will be elevated. That is a normal pattern. You see bilirubin elevated, low bilirubin, then SGOT, SGPT elevated. Then after some times, bilirubin start elevating. That time liver is actually going to fail. So the end stage, you get only elevated bilirubin. SGOT, SGPT will be becoming normal. That is called as liver necrosis. Okay. So this is a pattern seen in all type of acute liver injuries.
The patient was treated with antibiotics and other supportive measures, and his ultrasound was done, which was showing.
Why antibiotics are required in acute liver failure?
Sir, ideally, like we have to get a blood culture, urine culture, and everything should be done. And if positive, we have to start on
If negative,
antibiotics.
you don't give.
If it is a liver failure, we have to prophylactically start on
You have to
antibiotics.
give gram-negative coverage. Otherwise, there will be growth in the intra-abdominal area that produces again further damage to the patient. Hepatic encephalopathy aggravates. That's why we have to give gram-negative coverage.
And this patient's ultrasound was showing features of CLD, that's splenomegaly, and liver was showing co-secotexture with surface irregularity. And there the patient was started on supportive treatments and antibiotics, and he was referred here for like further management.
Any more labs you want to tell at this point?
Sir, outside, like we had the values of these liver enzymes and bilirubin and all. So with this background, he came to our hospital.
PTINR?
Outside INR value was like around 1.2 to like 2 range. It was not more
What's the
than.
relevance of INR?
Sir, if it is like a encephalopathy and coagulopathy is there, like it's like a acute liver failure we can term, and also it is a marker for if the patient is fitting into a liver transplant and all.
There are two functional investigations of liver. What are the two functional investigations? One is
vitamin K
PTINR, other one is albumin. So these are the two things produced for our body. Okay, STOT, STPT, all the markers of liver injury. But function is affected when the albumin is low or PTINR is elevated. So if you want to know the exact function of the liver, these two investigations has to be done. Albumin should be done and PTINR should be done.
And like with this background, he came to our hospital, and apart from this history, like there was no history of any like blood transfusions or no history of
the transfusion history is for what?
Like this liver failure. We don't know like what the causes CLD, like any hepatitis B, C.
Which hepatitis will produce acutely liver failure?
No, acute liver failure is mostly seen in hepatitis A, E, and all.
Will it transfer through blood transfusion?
No, it is like food and waterborne.
So why you are thinking about that?
Acute on chronic, like this patient is having a CLD feature, so we don't know the cause of CLD. CLD, like it can be maybe alcohol.
Nowadays, it is not very common blood transfusion induced liver failure as such because of this virus. But blood transfusion itself can produce so many problems like lung injury, liver injury, graft versus host reaction. So many things can happen after blood transfusion. Like that, if you think it is okay, but blood transfusion induced liver damage due to hepatitis is very, very rare nowadays. Even you think that transfusion produced hepatitis B or C, that may not produce this much damage. Acutely, very rarely it produces damage.
Then there is like no history of any chronic like food intake from outside or.
What food intake you want to rule out? What are food itemes can produce acute liver injury?
Basic. Mushroom toxicity.
Recently, in France or this one, 2 children they took this this called as death cap. Mushroom. That can produce liver damage. Okay.
There is like no history of any alternative medicine like herbs, herbal medicine intake or any like this Ayurvedic medicine like intake and all. Which
contains heavy metals.
And there is like no history from the patient as such revealing any toxicological intake like any paracetamol intake or rodenticide, nothing like that. Then
which rodenticide can produce?
The phosphates can cause liver failure. Then with this thing, other thing was like my medication, as I already told, he was on disulfiram, acamprosate and lorazepam. So among this, like disulfiram itself can cause hepatitis.
If they take alcohol.
Otherwise also like altered hepatitis can be there. So like while there is an active hepatitis, it's better not to start the patient on a disulfiram. And there was history of fever was like 1 spike during the outside hospital stay, and there is no history of like any travel from outside state or anything. No other history was there.
Any history of seizures in this patient?
Right now, sir, till now, no history of seizures, and the only symptoms were this fatigue, vomiting, and some altered sleep pattern. So coming to the secondary like examination, patient had icterus and like other system examination, per abdomen was like soft and non-tender. It was not distended. There was no features of any ascites. Then CNS examination, patient's GCS was full and there was no flaps. And there was no focal neurological deficits. Patient's chest examination air entry was bilaterally equal and there was no added sounds, and CVS examination was also within normal range. Like with this background and the history from the outside hospital, we went ahead with the like routine blood investigations. So for knowing his metabolic status, we had taken a venous blood gas. So venous blood gas was showing a respiratory alkalosis with a hyperlactatemia of lactate of 4.8. pH was 7.488. And
7.488. Okay, venous and arterial sample difference in pH
0.03 will be
very minimal. So it is a good investigation to get a immediate pH. What it tells you? pH is very high. Very high means it is more than
normal. So the patient may be having a like alkalotic
you want to think like that, or
apart
which is more relevant? You tell this patient is having alkalosis. What is the immediate thing should come to your mind?
Vomiting history was then
Tell me what is the reason? What is a common reason for an alkalosis in chronic liver disease?
Acidosis leading
Respiratory alkalosis.
Common cause for alkalosis in a chronic liver disease patient, which should alert the emergency physician. What is that? If you know only, you should look for that. Hypokalemic alkalosis is one of the most important alkalosis, which is dangerous to a patient who is having liver disease. Okay. Patient can have respiratory alkalosis like you told. What is the potassium here?
His potassium was 4.1.
4.1. So it is not there. Next you look for other causes. Other causes like you told, respiratory alkalosis.
Then like maybe secondary to this lactic acidosis, patient can have a tachypnea. But this is basically a respiratory.
That concept should never come to you, because somebody is having an acidosis. You are telling when he breathes fast, he will go to alkalotic side.
No, it will compensate.
Compensation means within the limit. It will be in the limit only. It has to pH will come to the normal. That's all. Compensation means that if it is going to alkalotic side, there is another cause for that. You should basically think. Okay. Vomiting can produce alkalosis because of the loss of the bicarbonate. Okay.
Then so
sorry, it will not produce
bicarbonate patient was 22.
Okay.
And the other investigation done was like a GRBS was 118.
What is the reason for this alkalosis? Potassium is normal. Is it a respiratory alkalosis? Since we took a VBG, it is very difficult to comment on that. But what may be the cause? Bicarbonate is normal. It's not high. Is there any reason? Or it's a false report? If there is no reason, then you have to repeat it in a better way to get whether the report is normal or not. You have to find out the reason, because alkalosis is not very good in a case of hepatic encephalopathy like this.
PCO2 was how much?
PCO2 was 30.8.
In a VBG.
VBG.
Okay.
It's a washout.
No, washout.
Mostly it is a washout, tachypnea. Mostly it will be respiratory alkalosis.
Like his GRBS was 118.
Sugars and ALF?
We have to rule out hypoglycemia because ALF patient is prone for hypoglycemia due to the depletion of the glycogen, hepatic glycogen stores, and gluconeogenesis. Both will be altered. And his lab showed like a hemoglobin of 13.5. His platelet was 11,000. 1,10,000, and his total count was 19,700 with a C-reactive protein of 45.1, and sodium was 131.3, potassium was 4.2, procalcitonin was 0.97. His urea was urea creat were within normal range. Creat was 0.53 and urea was also within normal range. Then SGOT, SGPT were like 2700.
Can you tell one condition where creatinine is low?
The muscle thing is low.
Any patient who is having chronic wasting of muscles, like chronic liver disease patient, so many patients, HIV or anything, if the muscle mass is low, you don't get a creatinine value like a normal person. That you should keep in mind. So basic creatinine in this patient is only 0.5. If there is a 30% increase from that state, you should think about renal failure, not like other patients. So it should be very careful.
Then the bilirubin was like 10.3 with direct component 7.52, and his INR was 2.08.
So this is after second value. From outside it was normal, it has come to 2.08.
And we don't know whether they had given like any vitamin K or the FFP or anything from outside hospital. We presume that nothing has been given, because no transfusion history was given, nothing has been given. And other investigation we did ammonia, which was like 106.
It's high.
It's high. And the routine, urine routine was done. It was showing 1 to 2.
Regarding ammonia, what sample do you send usually?
Arterial ammonia is usually sent.
And how should you send?
An ice pack. We have to take the arterial sample and have to be sent.
Proceed.
And other test done was
what is the importance of this ammonia in clinical practice nowadays?
It is if the ammonia is elevated with the condition correlating, we can say can be like a hepatic.
So hepatic encephalopathy, ammonia will be elevated. Is that level correlates with anything?
No.
Okay. There is no hepatic encephalopathy. There is no liver disease. Where else ammonia can be elevated?
Urea cycle disorders.
Okay. In children with seizure disorders, metabolic disorders, it can be elevated.
Then we have done a fibrinogen, and it was like 304 at the time.
304 is high.
It's high.
That means what?
Sir, basically this liver failure, everything can be a procoagulant state. Even though we say it is more like a bleeding tendency.
What is basically what is fibrinogen?
It is degradation,
clotting cascade.
What is it? Why it is?
It is a protein made by.
It is something like your CRP, platelets, CRP, fibrinogen, all are increased in acute inflammation. Once the patient go to DIC, it all goes down. Okay. So any acute phase like any other acute phase reaction, this fibrinogen also will be elevated in acute inflammation, like acute liver failure. But after 2-3 days, if you watch this patient, it slowly comes.
This was the basic panel of investigation, and his electrolytes were more or less normal, except for a phosphorus of 1.8.
Why do you think the potassium is high here?
Maybe it might have been corrected from outside.
That is the reason. Normally, potassium will not elevate like this in any patient. See, we are seeing so many patients. This patient might have received potassium. He might have had a hypoglycemia there in that hospital. That doctors might have given potassium. Okay. Otherwise, very difficult to tell potassium, get a potassium like this. What is the urine pH?
Urine pH.
So is it anything?
If he is on long-standing spironolactone also, it can cause
it can produce spironolactone can produce.
Sir, urine pH was.
Okay, now leave that.
6.
Okay, it's normal.
Urine pH was 6. With this was a basic lab investigations done, and phosphorus was 1.8. So we attributed it to the liver failure.
Phosphorus.
Because phosphorus will be used up by the liver for regeneration, so it will be coming.
This patient is having diarrhea?
No history of diarrhea. So
is it going to have any importance in ICU? deposits?
Yes, sir. Basically, mostly it is if the patient is ventilated and all during our weaning process, we like phosphorus is basically the ATP everything requires phosphorus.
Muscle
So the
action.
will be
So weaning will be difficult in hypophosphatemia.
hypophosphatemia. So if the patient is asymptomatic,
How do you correct this phosphate? Is
sir,
it important?
yes, in
Have you
ICU patient we will have to
So
correct
this
this.
patient, how do you correct oral or IV?
Since he is having like vomiting, we can like go for
This
IV
patient
preparation.
should be given IV correction.
So it is like a 15. We go for a pot force correction.
Okay,
So
that we'll discuss after.
and other routine like so we are right now having a patient like a alcoholic with a CLD right now presenting with a acute liver failure, that is he is having coagulopathy, hepatic encephalopathy and elevated liver enzymes, and since the symptoms had started like more than 1 week of time, we are calling it as a acute liver failure.
It's an acute liver failure.
So the cause the outside hospital the dengue IgM was positive. So we'll have to reconfirm.
To dengue also.
So we had to reconfirm it. So we had sent a repeat test from our hospital, and it had come to be like equivocal.
NS1 antigen?
Was negative, sir.
Negative. Okay. How many days fever?
Fever like around 10 days back, 7 to 10 days back he had the fever episode.
It's possible that he can have dengue also, because NS1 has negative, IgM is positive. That means immediate past infection can have same like picture.
So apart from this dengue, like we had sent for other hepatitis workups, sir. So hepatitis A, hepatitis E, IgM, and the pre-op serology like was done, and also this was the basic things done, and to know the like cause of CLD, other workup like ceruloplasmin, ferritin, and all was like.
What is the age of the patient?
Patient was 42.
Okay. Male patient.
Male patient. And we had also done a GGT, sir, to look for his alcoholic, like whether it's acute alcoholic intake is there. So it had come to be like 303.
Okay.
It is elevated, highly elevated.
Alkaline phosphatase?
Alkaline phosphatase was 207.
It's not very much elevated, not threefold elevation. If alkaline phosphatase is elevated, what are your differential diagnoses?
Some duct involvement, like obstructive.
Common things first.
Obstruction.
Obstruction is a common thing. SGOT, SGPT in thousands. Alkaline phosphatase is elevated. You cannot tell obstruction. Obstructive jaundice normally will have normal SGOT, SGPT or slightly elevated SGOT, SGPT. Then alkaline phosphatase. Here SGOT, SGPT is in thousands. So there is a problem in the liver and alkaline phosphatase is elevated. What do you think? Let's see. Young
High
patients,
metabolic.
Wilson disease. Any infiltrative disorders, including Wilson's or sarcoidosis or tuberculosis, all these things will have similar picture. Very high SGOT, SGPT and very high alkaline phosphatase. That means there is a liver injury, there is an obstruction in the intracanalicular. Even hepatitis A, B, all these things will have acute phase. SGOT, SGPT will be in thousands and alkaline phosphatase will be elevated. Don't think that alkaline phosphatase elevation is always an obstructive jaundice. It can be seen in obstructive phase of hepatocellular jaundice. So that should be very careful when you are interpreting these results. That is not a isolated elevation of alkaline phosphatase will tell you that there is an obstruction. But both SGOT, SGPT and alkaline phosphatase means there is a problem in the liver that has produced intracanalicular obstruction. Okay. A young patient who is having elevated alkaline phosphatase like this, you have to think about Wilson's disease also. But he is having an alcoholic liver disease. He takes alcohol. So we normally attribute everything to alcohol.
Then like this was the basic investigation answer. We are having like a alcoholic alcoholic with acute liver failure, with a coagulopathy with INR of like 2
So here you should have some scoring system.
Yes, sir.
That scoring system are required for, one is to tell the patient bystander that what is the prognosis. Other one is whether the patient require transplant or not. Third one, require steroid or not. 3 scoring system you have to tell.
Sir, so this patient, like, he had a child status of C. So child status basically attributes to the transplant thing.
Criteria.
Then he had a MEL score of 26. So MEL score basically it helps in prognostication.
Okay.
And there we takes different parameters like bilirubin, ascites, albumin, prothrombin time, and and encephalopathy.
Okay.
That is the MEL scores. And he had a matrix discrimination factor, like he had a score of 58.
Okay.
So it is basically, if it is more than or equal to 32, steroids is having some role in.
How does steroid help in alcoholic hepatitis? And if you give steroids in any hepatitis previously, once upon a time it was the treatment for most of the hepatitis. Now we know that many viral infection, if you give steroid, it can produce some
Flare up.
flare up. But steroid, how do it help in jaundice?
Basically,
How do it help?
Steroids.
What is the basic problem in hepatitis?
Inflammation of
It is
the-
inflammation. If
so
you give steroid, inflammation will come down. All the canaliculi will be free. The bile can flow very fast, and the jaundice will be completely disappeared. It was called as whitewashing of the liver. So if you give steroid, immediately patient will become normal clinically. All parameters will become normal. But what happens is, if it is a hepatitis B or C, something like that, it can flare up. That's why nowadays we are not recommending steroids in any of these conditions except acute alcoholic hepatitis. This patient, if you are in a peripheral settings, you can give steroid and try what happens to the patient. In acute phase, once the patient become peritonitis, all these things, complication levels, we cannot give.
So we didn't go for like a steroid therapy here, because of like highly immunocompromised status, chance of sepsis and all. Like we didn't go for steroid here, sir. And
But
so
according to the score, what you are told, he requires steroids.
This was a basic like score. According to the scoring, he belonged to child C, MEL 26, and with a MADRI score of 58. And he was like taking alcohol, so his alcohol withdrawal status was also checked for. So we checked the SIVA score, and it had come to be like 15, which was showing a mild withdrawal.
Okay.
So the patient was with this thing. The patient was like admitted to the ICU.
How do you implement SIVA score?
SIVA score, like we have to reassess the SIVA score like frequently, whether the patient is like worsening withdrawal or improving. So that like
here I think the frequency will be close to 1 to 2 hours, no, benzodiazepine.
Score
of 15.
Okay. So with that, every 2 hours, like we have to reassess it. So the patient was like admitted to the ICU, and so basic management of the patient will be like
emergency management of patient who is having acute liver failure.
So one thing is like we have
first you start from airway, breathing, circulation, disability, like that only you can tell.
Sir, like this patient, the airway was normal, patent, but
there is no breathing problem.
No, like A, B, C was normal. Disability also, he was having
if this patient develops hypotension, how do you manage?
So hypotension, basically, according to fluid status, we can give him like fluids, and later if it is not improving, we can go for other supports like noradrenaline, and this also can be taken like in a septic shock. We have to anticipate like adrenal insufficiency things. So if the patient's BP is not improving with the supports, we can give a trial of steroid, because the
fluid, noradrenaline,
steroid.
Okay.
And regarding airway management, most of the time the indication for airway management will not be a primary respiratory issue, rather than it will be
low
sensory issue.
Mainly after seizures, all these things.
And worsening encephalopathy.
Proceed.
So coming to ABC was normal. Disability, he was having a grade 1 hepatic encephalopathy. According to the West Haven's grading, he had a grade 1 hepatic encephalopathy.
What are the grades?
So grade 1 will be like altered sleep pattern. Grade 2 will be patient will be having some confusion along with the flaps will be there.
Flapping tremor is the that main feature of grade 2
hepatic encephalopathy.
Grade 3.
Grade 3 will be patient will be like stuporous, agitated,
altered
and all.
behavior, irrelevant talk, all these things.
Grade 4 will be hepatic coma. This patient had a grade 1 hepatic encephalopathy and he didn't have any hypoglycemia. And coming to exposure part also, he was febrile. And we had to prevent hypothermia. So ABCD was like normal. So while admitting, what all we have to check for is like the patients with the liver failure, hepatic encephalopathy, ICP will be elevated. There's chance of rise in ICP. So cerebral edema secondary to hyperammonemia will be
Cerebral
there
edema is one of the common complications.
in acute failure. So we have to admit the patient in a cool, calm and calm environment. Anything like that stress the patient or agitates the patient should be avoided. Adequate sedation should be
How do you sedate this patient?
Sir, if it patient is not having hypotension or bradycardia, we can go for dexmedetomidine if the patient is agitated and all, or a short term benzodiazepines, that too in a lower dose should be given.
Why diazepam cannot be given?
The metabolism will be prolonged, so the action will be more prolonged, leading to respiratory depression and all. Then coming after adequate sedation, while doing procedures,
Head and elevation?
Yes, we have to go for a head and elevation. That is that too is in reducing the ICP. We have to maintain a straight neck with a elevated head end. Then next thing is we have the hypoglycemia should be checked for routinely. It should be
you want to start dextrose in this patient?
Without a hypoglycemia
No, my question is, you want to start a dextrose solution in this patient?
No, sir.
When you want to avoid hypoglycemia?
No, if the patient is taking feeds, if he is
this patient is not taking feeds in ICU.
Not.
This patient's sodium is 131. How can you start dextrose without correcting that? First of all, when you are giving dextrose, either correct sodium and start dextrose, or you go for a DNS. Okay, so sodium is not very it is very important in this type of cases. Any patient who is having CLD, hyponatremia can produce acute problem in that patient. So you should be very careful. If you start dextrose, what will happen to sodium?
It will come down.
It will come down. Again, it will get diluted and come down. So you should be very careful. This patient's sodium is 130.
The metabolic parameters, everything should be corrected. Then we have to give for the anti-hepatic NCUF measures should be started. The bowel regime, the lactulose, everything should be started. Then
what is the action of lactose?
Sir, it is one thing.
What happens to the pH of the stomach after you take lactose?
pH increases.
pH increases, so
Absorption,
what happens to the bacteria?
Basically, the ammonia will be converted to ammonium, so the absorption will be reduced, and
that will be prevented by lactose. The pH alteration in pH will not allow the bacteria to grow there. Okay, so that is one thing. Then it removes the stool from the intestine. Two things. Okay.
Then
is it absorbable or non-absorbable?
No, non-absorbable. Then other thing is we can start on the L-ornithine, L-aspartate, and all those hepatoprotective things.
What's the problem with the lactose in hepatic encephalopathy or in ALF?
Basically, it is mostly allowed in the CLD patients. The lactose.
It can be given, but what is the problem? That is the question.
If in grade 3 and 4 hepatic encephalopathy and all, we have to be more careful.
But careful. What means careful means what? What is the effect of lactose?
It will cause diarrhea, so hypokalemia will be worsened.
So hypokalemia, not only hypokalemia, fluid loss, hypokalemia, so many things can happen if the patient develops more stools. So 2 to 3 stools are recommended when you are giving lactose. More than that, you should be very careful. Either you have to reduce the frequency of lactose or you have to stop it.
Then antibiotic coverage should be given.
What antibiotic coverage?
A broad spectrum antibiotic can be started.
Specifically for
gram-negative.
gram-negative.
You have to cover the gram-negative.
Gram-negative.
E. coli should be covered. Okay.
So we can go for a magnesium sulbactam or a piperacillin tazobactam.
Ceftriaxone will be enough. Okay, whatever you told.
Then other thing is some studies showing a prophylactic antifungal to be like provided if required. Then
Any role for prophylactic anti-epileptics?
no, sir. Ideally, if the patient is showing a seizure, we have to start the patient on anti-epileptic.
What will be the choice?
Like levetiracetam can be given, sir, and lacosamide also.
Acute control?
Levetiracetam will take some time. So before that, how do you?
Short-acting benzodiazepines.
Which one?
Midazolam. Then apart from this, other things to be done is other like supportive measures. If the patient is going into renal failure, we have to support with renal
Renal
replacement.
failure. What are the causes for renal failure in CLD?
Sir, can be like a hepatorenal syndrome, or it can be due to the hypotension. It can be like secondary to sepsis, or it can be like
Recurrent UTI leading to pyelonephritis. Inadequate perfusion.
Okay. Inadequate perfusion will become
HRS.
HRS. That is HRS, but irreversible. That is irreversible. Due to some reason like hypotension and all, it can produce. It is reversible.
Then if it is the ALF is secondary to some toxins, which has a nephrotoxic element also.
Okay.
Sometimes it's mushroom poisoning and all. It has both nephrotoxic and hepatotoxic effects. Like that. And maybe like secondary to some drugs like antibiotics, sometimes like given nephrotoxic drugs or something.
Which antibiotic is nephrotoxic?
Like if we are on vancomycin.
One dose can produce renal failure. What is that? Aminoglycoside you told, that is correct. But how many doses it required? It is a cumulative effect. Normally, aminoglycoside induced renal failure is a cumulative effect. So first day you don't see anything, second day also you don't see anything. Third onwards, creatinine start elevating. So should we stop the drug in such conditions?
Hydration.
Based on the
Hydration
trough
will
levels
not
and
work.
creatinine clearance.
Creatinine clearance.
So if it is absolutely indicated, you have to reduce the dose of the drug. Then that can be avoided. If it is not absolutely indicated, better stop the drug. Okay. Fluids will not help in that situation. Okay. Aminoglycoside induced will not revert without stopping the drug.
And other thing is like if the patient is like having a worsening of encephalopathy or like this coagulopathy and all, we have to like ideally check for the liver transplant status and all. So if, in a patient with acute liver failure, ideally the patient should be like transferred to a liver transplant setup, because in most like some of the cases it will be the ultimate treatment. So like a patient should be transferred to such
Any
a
criteria is there for transplant?
That is the King's College criteria will be
Basically,
there.
it is designed for paracetamol.
Non-acetaminophen is also there. So that is a criteria will be like if the prothrombin time is more than 100, or like it has 5 criteria from which at least 3 should be met. That is a non-hepatitis A, hepatitis B, like or idiosyncratic like or halothane related. Then if the patients bilirubin is more than 17, then creatinine is more than 3.74, then jaundice more than 70s. All these criteria.
Non-B.
So if from this 5 at least 3 is met, then a patient can be taken up for a
Can we give FFP in this patient?
Sir, if at all the patient is not having any bleeding, better not to give FFP, because FFP will mask the INR derangement. So we won't be knowing the the transplant criteria, like when the patient can be taken up for transplant.
Deterioration will be masked.
So
Other than bleeding, any other indication for FFP? With procedures, any invasive procedure, then you are justified in giving.
Suppose you are doing a procedure in a neurosurgical procedure, you have to correct platelets and coagulation. That time you cannot wait, so you better give and do it.
And if the patient is like further worsening sensorium and distress and all, better to like go for a early intubation and airway protection, and to sedate the patient to reduce the stress and all this.
Role of N-acetylcysteine?
Sir, N-acetylcysteine as such was initially started for like a paracetamol related liver failure, but it has been used in other acute liver failure conditions. So we can give an infusion of N-acetylcysteine, which is proven to be of benefits in other hepatitis, like ischemic hepatitis and all. It has been proven benefits.
Any thoughts about bridge to transplant? The patient is waiting for transplant. What all the options at those points?
So like we have the certain supportive like measures like the plasmapheresis or like the thing is like a mass that is like a molecular adsorbent recirculating system. So where it is a albumin related dialysis. Basically it taps dialysis won't be removing the albumin bound molecules. Here the albumin bound molecules like bilirubin will be removed along with other water
Why should we
soluble.
remove bilirubin?
Sir, in like
If
hyperbilirubinemia,
bilirubin increases, what happens?
it can like lead to renal failure and all this. Sir.
It produces encephalopathy. That is one of the most important thing. What we are clinically seeing. Again, it can produce damage to like SI node. It can affect kidney. It can affect everywhere. It can affect. But main thing what we are seeing in the patient is hepatic encephalopathy.
Any role for mannitol in LF?
Sir, if the patient is having raised ICP, cerebral edema, we have to give mannitol, sir. So it is like 0.5 to 1 gram per kg. IV should be given. Like fast infusion should be given. And also like we have to start the patient on hypertonic saline, sir, like anti-edema measure. And we have to maintain a map of like around 65 to 70 and cerebral perfusion pressure like around 50, and ICP should be like maintained like below 20, like around 20-25. And another thing is like in ICU and all, if a patient is so unstable to be shifted to for imaging to rule out like a raised ICP, we can go for ultrasound like optic nerve sheath diameter can be like measured as an indirect measure of the ICP.
Can you put a central line for this patient? Is INR is 3? Is it contraindicated?
Ideally, like we have to correct the coagulopathy.
You cannot correct, no? This patient requires transplant.
Right now, the patient ultrasound guided can be done.
It can be tried because that sometimes it will not produce any major bleeding. Bleeding occurs, then sometimes you will have to give FFP and correct it. Otherwise, don't try to give FFP and put a central line.
But our patient, like during the initial phase, like he didn't have any inotropic supports or multiple infusions, which warranted a central line insertion.
Okay.
This is one place where rarely femoral has some preference over necklines, traditionally. Okay.
Okay. Thank you.